All right, let's jump right into a topic that is absolutely critical for anyone treating cancer patients: cancer-associated thrombosis, or CAT for short. It's incredibly common, it can be really serious, and knowing how to handle it is a must. So, let's get into it.
First things first, let's just absorb the scale of this problem. Having cancer isn't just a small risk factor for getting a blood clot, it's a massive one. It bumps up the risk of a venous thromboembolism, a VTE, by 4 to 7 times. That is huge. This isn't some minor detail, it's a core part of the disease itself. So, what are we actually talking about when we say cancer-associated thrombosis? Well, it's pretty straightforward. It's the official term for when a patient with active cancer develops a blood clot. That could be a deep vein thrombosis, a DVT, usually in the leg, or a pulmonary embolism, a PE, which is a clot in the lungs. And the key thing here is, this isn't just random bad luck, it's a direct result of the cancer.
Okay, so that leads us to the big question, right? Why? Why does cancer put the body in this state where it's just so ready to form clots? Let's dig into the biology behind it.
You might remember this from your training: Virchow's triad. It's the classic 3-part recipe for making a blood clot. And what's wild is that cancer just lights up all 3 parts of the triad. First, you get hypercoagulability. The tumor cells literally release chemicals that make the blood stickier. Second, endothelial injury. Things like chemotherapy and central lines rough up the inside of the blood vessels. And third, venous stasis. If a patient's not moving much or a big tumor is pressing on a vein, blood flow slows right down. So cancer hits all 3. A blood clot isn't a coincidence, it's an almost predictable outcome.
So we know the risk is high. The next logical question is, how do we spot it? This is all about clinical practice, knowing which patients are most likely to get a clot and what to look for when it happens.
Now, not all cancers are created equal here. Some are much riskier than others. For solid tumors, pancreatic cancer is number 1, by a long shot. Then you have stomach, lung, brain, and ovarian cancers. And in the world of blood cancers, multiple myeloma and lymphomas are the big ones. So if you have a patient with one of these, your VTE alarm should be on high alert. And how do they show up? Well, it all depends on where that clot is. If it's a DVT in the leg, you're looking for signs in just one leg: swelling, pain, maybe some warmth. But if it's a PE in the lungs, the symptoms are much more dramatic and sudden. Think sudden shortness of breath, chest pain, and a racing heart. They're 2 different presentations of the same underlying problem. Now, here is an absolutely critical clinical pearl. A lot of the PEs we find in cancer patients, they're silent. We just stumble upon them on a CT scan we ordered for something else, like cancer staging. And here's the takeaway, and I can't stress this enough: an incidental PE is not an insignificant PE. Just because you found it by accident doesn't mean you can ignore it. It carries the same risks and demands the exact same full-on anticoagulation treatment, no exceptions.
Okay, pop quiz time. Your patient with lung cancer comes in with a swollen, painful leg. In a different setting, your first move might be to check a D-dimer. Is that the right move here?
The answer is a hard no. Do not order a D-dimer. It's basically useless in this situation. Why? Because the cancer itself causes inflammation that cranks up the D-dimer level anyway. So a positive test tells you nothing new. You just skip that step entirely and go straight to the real answer: imaging. That means a compression ultrasound for a DVT or a CT scan for a PE.
So you've confirmed it. There's a clot. Now you've got to make probably the most important decision in managing CAT. What anticoagulant are you going to use? And really, the choice boils down to 2 main options: the injectables, which are low molecular weight heparins, or LMWH, and the pills, which are direct oral anticoagulants, or DOACs.
So let's make it real. You've got a patient with stomach cancer and they've just been diagnosed with a PE. They can swallow pills, no problem. So what do? Do you go for the easy option, the oral DOAC pill, or do you go with the LMWH injection?
This is where it gets tricky, because there's a really important trade-off. Yeah, DOACs are pills, which everyone prefers. They're convenient. But, and this is a huge but, they have been shown to cause more bleeding, especially in patients with gastrointestinal or genital urinary cancers. And that's exactly why LMWH, the injection, is still the safer preferred choice in that very common situation.
So let's be super clear about this. When should you definitely lean towards LMWH? Well, if your patient has any active GI cancer, like stomach or pancreatic, or any GU cancer where there's blood in the urine, or really, if they just have a high bleeding risk in general. It's also your best bet for patients who are vomiting and can't keep pills down, or those with really poor kidney function.
And there's a solid reason for all this. It's not just an arbitrary guideline.
GI tract tumors are often what we call friable. They're fragile, they're delicate, and they bleed really easily. And for whatever reason, DOACs seem to really amplify that risk of bleeding from mucosal surfaces like the gut lining way more than LMWH does.
Okay, so you've made your initial choice of drug, but we're not done yet. The management of CAT is a long-term game. So let's talk about how long to treat and a few special situations that you're definitely going to run into. For a regular blood clot in a healthy person, you might treat for 3, maybe 6 months. But in a cancer patient, the rules are different. The absolute minimum is 6 months. And very often, you're going to continue that treatment indefinitely, for as long as the cancer is active. Just think about it. The cancer is the ongoing risk factor, so as long as it's there, the protection needs to be there too.
Here's a super common problem. What do you do when chemotherapy has knocked their platelet count into the floor? There's actually a pretty simple stepwise approach. If the platelets are above 50,000, you're good. Continue the full dose. If they drop into that 25,000 to 50,000 range, you just reduce the dose. But if they fall below 25,000, the bleeding risk is just too high, and you pretty much have to hold the anticoagulation until they recover.
And what if they get another clot while they're already on treatment? Well, there's a standard playbook for this too. If they were on a DOAC, that's considered a treatment failure for that class of drug. You switch them over to LMWH. If they were already on LMWH, you just stick with it, but you bump up the dose by about 20 to 25%.
Okay, wow, we have covered a lot of ground. So let's bring it all home and boil it down into a simple 5-step action plan you can use in your daily practice.
Here it is, your mental algorithm for CAT. Number 1, suspect it. Have a high index of suspicion in any cancer patient. 2, confirm it with imaging. Skip the D-dimer. 3, assess their bleeding risk. Think hard about where their tumor is located. 4, choose your weapon wisely, LMWH versus a DOAC, and default to LMWH for those GI cancers. And 5, treat for the long haul. As long as the cancer is active, the treatment is active.
And I want to leave you with one final thought. One sentence that I think reframes this whole topic perfectly. When you're trying to decide how long to treat one of these clots, the most important factor isn't the clot itself, it's the cancer. Remember this line: duration is cancer-dependent, not clot-dependent. If you keep that single principle in mind, it will guide you to make the right call for your patients every single time. Thanks so much for joining me.